I keep hearing this thing is simple, but I see problems. So I'm Bob BURKARD. Here are my disclosures. I've been a member or chair of all of these ASHA committees. ASHA would be mortified if I were to say I represent them. I represent my opinion here today and nobody else's. So here we go. I think we can all agree that the Patient Protection and Affordable Care Act has been uncontentious and the rollout has been smooth. But part of the reason we're here and part of the reason I'm trying to say, you know, what the audiology profession and the various organizations are doing is a lot of folks in healthcare are concerned about the changes that are coming. And despite a bill that's about this thick, there are very few details, and I think we have to look into our crystal ball and see what is going to happen, but we have to prepare, and I'd like to spend the next 10 minutes or so talking about what we're doing as a profession. And the first change is going from a fee-for-service to a value-based care system. That's really very critical, and I have a quote here, from Porter that says, that basically we're talking about value-based purchasing, and that value isn't about more care, it's about better outcomes. And how many of you, after having an endoscopy, would go back for a free second one later that week? But honestly, that's sometimes what we want. We say we have this idea that more care is better care. And that isn't true. Actually, a better diagnostician should need fewer tests than a poor diagnostician. And a good rehab person should need fewer, episodes of treatment. And so fee-for-service encourages increased utilization. And that probably rewards the dishonest and the incompetent, at least at times. And so we have to go away from this and get away from the assumption that more services are better outcomes. And so we really, truly have to get into the game of how do we optimize value in healthcare. And basically, the value is the quality of the outcomes divided by what the costs. So I'm having no trouble with this, Howard. And so let's talk about bundling and then follow with unbundling. Bundling for CPT codes has been going on for a while. So when we do a CPT procedure, we can bill for a variety of individual services, audiometry, acoustic emittance, or whatever. And there are single codes just for doing threshold estimation, maybe speech recognition. But when we do tests more than about 50% of the time together, there's a bundled code, and we charge for that. And here's something that will surprise you. We get paid for less in the bundled code than the individual codes. And so because, again, we're trying to save money. Why? Because 1/6 of our gross national product in the U.S. is paid in healthcare, and we can't afford that anymore, and we can't afford the growth. And so this bundling of services for CPT codes is probably going to continue, and at the highest level might end up being paying for an episode of care. So a patient comes in with a particular disorder based on an ICD-10 code, and we pay X amount for that based on some severity estimate. And so now let's talk about unbundling of hearing aids. A lot of patients come in and say, why is the hearing aid so expensive? Well, the hearing aid is somewhat expensive, and there's a lot of reasons for that, but you're also paying for our services. And I don't know why people are embarrassed about that. I don't know the last time that you went to have a knee replacement and you brought the joint in from, you called and online you bought a knee joint, you brought it in and said, oh, would you guys implant this for free? I don't think that happens. So why are we so bloody embarrassed to say we're charging for our professional services? That if you want, fitting a hearing aid isn't easy. I don't think the audiogram is a very good measure of functional outcome. And so we need to do a variety of tests. We have them coming in with problems. We have to do a lot of work in order to have them have a good outcome. And so we charge for those services, but the patient might think they're just getting a hearing aid. So that's bundled. Hi, I'm giving you this hearing aid and you provide those services, but apparently they don't count them for anything. I don't think that argues for the value of the care we provide. So now we have online hearing aid sales. We've heard about this. It's starting. It's going to happen. and you sit there and the patient comes in and it costs them much less to buy that hearing aid online than it did for the hearing aid you're offering. And there could be a difference in quality of the hearing aids, or the services you're providing. So you decide, you're a family practice physician living in the Midwest and in rural America. You decide, you know what, nobody else is providing healthcare. I'm going to buy some hearing test equipment and I'm going to provide the test myself. Fair enough. I actually don't mind that. If you charge one patient for that assessment and another patient you don't charge, you are actually in trouble because you can't provide, at least for Medicare patients, free services for some, but not for all. So you have to either not charge anybody, which I don't think is saying much about the value of the service, or you have to charge everyone. But also, if you don't charge for those services, and all you do is sell them the hearing aid, and let's say you make $500 on the side to underwrite the costs of what you're doing and your time, then you have a patient who buys the hearing aid online, they come in and they say, can you provide all of these services here? And for free, because that's what you provided everybody else. You might have to provide those services for free for those patients who bought their hearing aids online. So again, I think it's important we value the services we provide, that we charge, and if Medicare won't pay for it because it's not medically necessary, we charge anyway, and they can pay privately. So we've talked about value here at the beginning. How does one code for outcomes? Because values aren't about, oh, look at all the services we provided. It's about quality of care and outcomes. So how do we code for outcome? And one thing we have to do is we have to code for the disorder, and that's where the ICD codes come from. ICD, can be traced back to the primordium of public health and epidemiology. It was the International Classification of Death. I always think of Monty Python and the Holy Grail when I think of that. But now it's International Classification of Disease. And there's a clinical modification. ICD-9 has 18,000 codes, while ICD-10 is almost an order of magnitude more. So now you actually can code for noise-induced hearing loss due to dolphin encounter. No, I'm not joking here. And so we have a level of specificity here for the noise effects on hearing loss. The echolocation signal of the dolphin while you're swimming with them in Cancun gave you a noise-induced hearing loss. So now, other contact with dolphin. There's dolphin bites, there's bird bites. So we have a level of specificity. I don't like the way the hearing is coded in ICD-10, and I know a lot of other people don't. We still need to do work. But we can get at a level of detail that we couldn't before, which is a good thing. But I think somebody mentioned ICF, the International Classification of Functioning, Disability, and Health, earlier in the day. And I think we, at the very least, could code for level of severity with an ICF-like Likert code from 0, no problem, to 4, complete problem. So here's the ICF brief course set. There's a longer one. ICF has these 4 areas: body structure, which might be most akin, to our cytolesion testing that we code in ICD. But it also includes body functions: notice, attention, memory, emotional functions, which might be coding dementia, associated dizziness, tinnitus. But it also gets at environmental factors and activities and participation. And these are important. Hearing loss, has technology with it that we've heard about, and that could be over here or over here. It affects family relationships, our education, our access to health services. ICF is a much broader framework to talk about the consequences of hearing loss. So again, in the quality side of things, the Physician Quality Reporting System, PQRS, was designed by CMS to improve the quality of care by providing care metrics for the services you provide, and they're linked to CPT and ICD-9, soon 10 codes. And it started out as voluntary, just voluntary reporting for Medicare Part B fees, service, but the Patient Protection and Affordable Care Act, Obamacare, includes a transition from incentive for participation to penalty to non-participation. We only have a few codes for audiology. Remember, we're reimbursed only for diagnosis, so diagnostic quality estimates are a little harder than rehab. So why should anybody be involved for PQRS? The reason is money. Happiness does not buy you money in healthcare. And so to avoid the 2% penalty in 2014, folks have to report on at least 50% of qualifying patients for 3 measures. And to receive the 0.5% incentive, you need to report on 50% of qualifying patients for 9 measures or as many as are available. So how many measures does audiology have available? Right now, 1 measure is all. That's just audiology, and that's for making a medical referral for dizziness. We can also use smoking cessation, counseling, blood pressure measurement, pain assessment, falls prevention. We've had some arguments over a few others within committee. And currently, the Audiology Quality Consortium, which consists of 10 audiology organizations shown below, is working on 6 measures for future use, and we're partway through the process. Speech and noise for cochlear implant referral, functional communication ability, a tinnitus screening and evaluation, that's 2, ototoxic baseline measurement, monitoring, and vestibular testing. And I'm not going to go into detail on them, but they're moving forward. And so we are developing those measures, but it'll take us a while to get to the 9 measures we want. So we've been talking about how hearing loss is really important and that we should provide hearing loss services, especially to elders. And yet, if we go and look at the Obamacare exchanges and Medicaid programs, on this list here of essential health benefits, does anybody see audiologic or hearing services directly? We've talked about rehab and habilitative services and devices, so it might be in there. And prevention and wellness services might be our screening. Nowhere in there does it say we need these services. So if they're not specified specifically, as an essential health benefit, it seems unlikely most accountable care organizations are going to include them. So we need to make our services, our hearing services, essential. And what do we need? We need evidence that what we do makes a significant difference in the outcomes. And as a profession, between audiology and otolaryngology, we don't play well together. There's plenty of evidence that audiologists are capable to diagnose hearing conditions associated with significant morbidity and mortality. Dave Zappala's study comes to mind here. And yet, AAO-HNS strongly opposes direct access for audiology. And so even though AAA has supported direct access in recent years, the American Academy of Audiology, to me at least, it seems unlikely that's going to pass in the short term. So AAA likes direct access. The American Speech and Hearing Association is currently pushing the comprehensive Medicare coverage for audiology services. That is, we can be reimbursed for treatment. Also, while the Academy of Doctors of Audiology is campaigning for limited licensed physician status, direct access, and expanded audiology benefits under Medicare. So my personal opinion, do we care about the consumer? If we do, I think elders, if we want them to live independently longer and to reduce medical noncompliance, because those elders do not understand what their physician is telling them, and to affect their quality of life, I think we should support legislation that mandates Medicare cover the cost of hearing aids and allow audiologists to be reimbursed for their rehabilitative services. We also recently have been engaging in some interprofessional activity as a profession. And IPE is a hot topic. It has been for a decade plus. And mostly in the recent past, medicine, nursing, pharmacy, and some public health have been the central focus of IPE. Speech and hearing, OT and PT are starting to jump into that game now. However, right now, there's no clear evidence that interprofessional education leads to increased value in healthcare, especially in hearing services. So to end, and to stand on the soapbox about research areas, the audiogram is not a good functional measure of hearing. We got to start investigating hearing-related disabilities using a hearing handicap scale and/or speech and noise measures. We really need to move away from a disease-based scale of hearing loss to a functional-based scale like the ICF, the Corset, or the brief Corset, to get at levels of severity of hearing loss, quality of life, and as well as quality of care metrics. We have no good site of lesion testing for the various causes of sensory neural hearing loss, whether it's strial, interhair cell, synaptic, or neural. I think we need better tests, and that should be supported. I think there are strengths and limitations to correlational research. A correlation between hearing loss and dementia does not mean that treating the hearing loss will reduce the incidence of dementia. I appreciate the preliminary data available on this, but we really need data that suggests there is value in adult hearing screening and that there is a relationship, a causative relationship between hearing loss and dementia. Medicare is broken, needs to be fixed. Our valuation system for codes, the RUC and the RUC-HICPAC, is at best flawed and at worst biased. And we need some funded pilot projects to investigate the value of direct access for audiologists and what happens to quality of care when audiologists are reimbursed by Medicare to provide rehabilitative services. Thank you. They're the folks who helped me. Oh. Nah, it's okay.